Hi, everyone. Welcome to the Reframing Eye Care podcast. Today's guest is Dr. Caleb Abbott. He's been a guest in the past talking about dry eye, and that was one of the most viewed podcasts of 2024. So I wanted to have you back on to discuss, new things in dry eye. And basically, today's podcast is talking about dry eye pain, corneal nociceptors, and TRP channel dynamics. So welcome to the podcast.
Thanks for having me, Maria. Glad to be here.
Yeah, a lot of optometrists, this is all new concepts. So I want to learn more. As optometrists, we focus on, the corneal layers during the slit lip exam. But we don't always get a deep dive into, the corneal nerve anatomy and function. So today we're going to talk about the corneal nociceptors and the ion channels. So why is it an important topic for us to understand?
Yeah, I think this is something that we haven't really thought about probably since we were in our anatomy and physiology classes in optometry school. My professor was Dr. Bergmanson, who taught us some of this stuff, and I think I promptly forgot all of it. But I think understanding corneal nerve anatomy and physiology helps explain the dry symptoms that our patients are actually experiencing. So nociceptors or pain receptors is what's driving the symptoms that our patients feel. So if we don't understand what is triggering our patient's symptoms or how the pain is actually relayed to the brain, then it's difficult for us to understand dry eye.
Yeah. So let's start with the basics. What's the different types? And, can you give us information on nerve fiber types as well?
Yeah, so to start, the corneal nerves have two different fiber types. So we have A fibers and we have C fibers. The A fibers are myelinated and straight fibers. The C fibers are smaller with no myelination. And these are the ones that actually become the free nerve endings that are conveying senses of pain that our dry patients are experiencing. And the C fibers comprise the majority of our corneal nerves. And then we have three different types of nociceptors. So when you hear the term nociceptor, you can just think of pain receptors or sensory neurons. So the first nociceptor that the corneal nerves have are the polymodal nociceptors. These comprise about 70% of the pain receptors in the corneal nerves. They're associated with A and C fibers, and these polymodal nociceptors are detecting a wide variety of stimuli. So mechanical, heat, chemical, tear osmolarity, things like that. Then the second type of pain receptor or nociceptor is the mechanonociceptor. So this is about 20% of the nociceptors or pain receptors that our patients have in their corneal nerves. They're associated with those A fibers, and they're responsible for sensing kind of an acute touch or a pressure sensation. So think about whenever your patients have trichiasis and something's hitting them in the cornea and they're feeling that pain. That is being driven primarily by the mechanonociceptors that's detecting that touch and that pressure on the cornea. And then the third type of nociceptor is the cold thermoreceptor, which actually is not a true nociceptor in the sense that it doesn't actually convey a sense of pain whenever it's stimulated. But the cold thermoreceptor, which comprises about 10% of our pain receptors, are actually detecting tear film evaporation and tear osmolarity of the tear film. And the cold thermoreceptors are associated with A and C fibers.
Oh, so it gets even more complex, right? Each nociceptor has its own ion channel, is my understanding. Can you explain this?
For the nociceptors or those pain receptors to be stimulated, there's an ion channel that first has to get stimulated, and that's what leads to the action potential from that pain receptor. So when we're trying to understand what's actually stimulating the pain receptors, we have to look at those ion channels of the pain receptors. So the polymodal nociceptors, there are a few different types of ion channels, but the one that is the most important for us to understand is TRPV1. So the TRPV1 ion channel is again associated with those polymodal pain receptors that detect a wide variety of stimuli. And TRPV1, that ion channel, when it's stimulated, it plays a key role in dry eye symptoms. So most of the time that our patients are coming in with burning, stinging, discomfort, foreign body sensation, things like that, that's going to be driven primarily by that TRPV1 ion channel of the polymodal pain receptors or nociceptors. But if that TRPV1 ion channel is stimulated too much, then it promotes inflammation that we see in dry eye. And if that TRPV1 ion channel continues to be stimulated, it can lead to a peripheral sensitization of the corneal nerves when we think about something like a neuropathic corneal pain. Then there's another ion channel called TRPA1 that's associated also with the polymodal pain receptors or nociceptors, but we don't know much about this ion channel. We think it plays a role in corneal nerve inflammation and probably plays a role in allergies. And then the mechanonociceptors use the ion channel PASEO. So the PASEO ion channel associated with those mechanonociceptors is really detecting changes in pressure. So they're baroreceptors. So it's detecting pressure from physical touch. And interestingly, these are the same ion channels associated with mechanonociceptors that we have in our stomachs. So whenever we're eating a lot of food and our stomachs start to get full, it's actually the PASEO ion channel of the mechanonociceptors that are telling you, wow, your stomach's getting full. And then that's leading to the production of satiety signals and satiety hormones that are sent throughout the body. So really interesting, similar to what we have elsewhere in the body as well. But probably the most interesting ion channel, and the one that's probably the most pertinent for the listeners, is the TRPM8 ion channel. So the TRPM8 ion channel is associated with the cold thermoreceptors. Remember, the cold thermoreceptors are the pain receptors that aren't exactly pain receptors. They're trying to detect tear film evaporation and osmolarity. So your tears actually have a warming effect on your cornea. So the tears are warm. So when they're coating the cornea in the ocular surface, it actually warms up the cornea. But as those tears begin to evaporate, you actually get a cooling off of the cornea. So as the cornea begins to cool, it leads to the TRPM8 ion channel being stimulated, which then tells your lacrimal glands through those cold thermoreceptors to produce more basal tears. So this TRPM8 ion channel is detecting that cooling off of the cornea as the tears begin to evaporate. And also as your tears begin to evaporate, you get an increased salt content in the tears because there's less liquid, but the salt still remains. So you get an increased osmolarity. So this ion channel is detecting essentially surface wetness. So how much tears are present on the eye, indirectly based off the temperature of the cornea, and then tear film osmolarity. And when the TRPM8 ion channel is stimulated, it's telling the lacrimal glands to increase basal tear secretions. So not reflexive tears, because that's actually stimulated by the TRPV1 ion channel of the polymodal pain receptors, but the TRPM8 ion channel of the cold thermoreceptors is stimulating basal tear secretions.
Oh, that's a lot. What's the term that is used for discussing various diseases and disorders?
Yeah, so throughout medicine, there's a term called channelopathies that are commonly used. We don't hear about this much in eye care. Optometrists, ophthalmologists are not really familiar with this term, but it's very familiar in many other healthcare specialties. So like cardiologists and neurologists and physicians like that. So channelopathy is a common term that's just referring to the dysfunction of any ion channel within the body. And we know that dysfunction of various ion channels within the body lead to certain diseases. So channelopathies are linked with a whole lot of different disease states that affect like the kidneys and the liver and the musculoskeletal system and patients' hearts and the central nervous system. So one example that I find to be an easy example is my wife is a pediatric neurologist that treats epilepsy. And there's a lot of genetic conditions out there that affect the production and the function of ion channels that end up leading to seizures. So you have an ion channel that's not working well, so it's a channelopathy, and it leads to these patients or these little kiddos having seizures. So there are drugs out there that specifically are targeting those ion channels, trying to restore proper function to those ion channels to treat the seizures. And we do know that these ion channels, when they aren't working well, it can lead to certain disease states. And we know that when it comes to the eye, you have to have proper function of all these ion channels to maintain ocular surface and tear film homeostasis.
Yeah, well, I mean, there's a lot of promising drugs. Can you give us some overview on these drugs and aim to do, and when they might start seeing them approved through the FDA?
Yeah, I think that's a really interesting question, because if we can target the TRPV1 ion channel, remember that's the ion channel that is associated with those polymodal nociceptors that are very prevalent within the corneal nerves. And when those nociceptors are stimulated, this is what's driving our patient's symptoms. So if we can come up with a drug that antagonizes that ion channel, then theoretically we could reduce our patient's symptoms and we could reduce inflammation and decrease the chances of our patients developing like a neuropathic pain. So there's one drug out there that is a TRPV1 antagonist. That's pretty late in terms of development right now, going through, I think, phase 2 and phase 3 trials, but it's trying to inhibit the nociceptive signaling from those polymodal nociceptors just to decrease pain in our patients and irritation in our patients. Then there's another drug out there, and we're actually involved in the clinical trials for this drug that is actually trying to decrease the synthesis of those TRPV1 ion channels. So if you have less of these TRPV1 ion channels with the polymodal pain receptors, then our patients are going to be feeling less pain in general. So the goal of this drug was to reduce pain, redness, and try to improve tear film quality and decrease inflammation. But unfortunately, that drug failed to meet the clinical endpoints in a Sjogren's syndrome trial. But probably the most promising drug out there that we should know about in a couple months, whether or not the FDA is approving it, is a TRPM8 agonist. So remember, TRPM8 is the ion channel associated with those cold thermoreceptors, which are not true nociceptors in the sense that they don't convey a sense of pain. If anything, when that pain receptor is stimulated, you actually feel a sense of cooling. So there is a drug coming out called acoltremon that's being produced by Alcon, and this is a TRPM8 agonist. So you're trying to stimulate that ion channel of the cold thermoreceptors. So when you do that, the corneal nerves are going to tell the lacrimal glands to increase basal tear secretions. So it's trying to take patients that essentially are having dysfunction of that TRPM8 ion channel, maybe associated with aging, because we know that can happen, and trying to stimulate that ion channel so that you're actually producing more tears in these patients. And it can help restore tear film homeostasis and proper tear fluid dynamics for our patients.
It's a lot of information that you gave us. I mean, a lot of new things that I didn't even know. I mean, we never even learned in school. For the listeners, just, practice. They're not doing clinical trials. How can this all tie back? How can we bring it into our practice, get this new information to know what's coming up and better treatments for our patients?
Yeah, I think it sounds complex because we don't think about it very often, but it's pretty simple when you actually start to break it down. There are these pain receptors that are driving the symptoms in our dry eye patients. So we should do our best to try to understand what pain receptors or nociceptors are there. And we have to understand that these pain receptors, when they're stimulated, that's what's leading to all the symptoms that our patients are experiencing in dry eye. And pretty soon, there's going to be therapies and drugs that are coming out that are specifically targeting some of those ion channels associated with those pain receptors. So it's good for us to understand that these pain receptors exist, that these ion channels exist, and to start learning about them, because probably later on this year, we're going to start to see some drugs coming out that are targeting these ion channels.
Yeah. Well, thank you so much for coming on the podcast, giving us an update. Always learn so much from you, and always feel like I don't know anything on dry eye after I talk to you as well. So again, I hope the listeners can, get some information from this, bring it back to their practice. But if they want to email you and ask questions, is there someone that can contact you?
Yes, absolutely. My email address is just my first name and last name. So CalebAbbottOD@gmail.com. And I'm happy to answer any questions that come up. I find this topic particularly fascinating.
Yeah. Thank you so much.